Greetings from Indian Journal of Anaesthesia. I, Dr. Riniki Sharma, is going to present an article published in the latest issue, that is August 2024 issue of Indian Journal of Anaesthesia. It is titled Comparison of Propofol versus Dexmedetomidine Sedation for Awake CMAC D-Blade Video Laryngoscopic Nasotracheal Intubation in Patients with Difficult Airway, a randomized clinical study. Awake fiber optic bronchoscopic intubation is the gold standard for difficult airways, but it remains a highly underutilized technique. CMAC D-blade video laryngoscopy guided intubation under conscious sedation offers similar safety and success rate while being quicker, more user-friendly, and less dependent on patient cooperation or sedation. The CMAC D-blade is also more amenable to suctioning of secretions, blood, and slough. Sedatives like dexmedetomidine, midazolam, propofol are used for sedation and amnesia during awake tracheal intubation. Dexmedetomidine provides sedation with minimal respiratory impairment and provides hemodynamic stability with good tracheal intubating condition. Similarly, propofol blunts the pressure response to awake tracheal intubation. This study aimed to compare propofol with dexmedetomidine for conscious sedation augmented with local anesthesia for CMAC D-blade guided anticipated difficult nasotracheal intubation. So the primary outcome was intubation scores in between the two groups. The secondary outcomes were heart rate, mean arterial pressure, intubation time, number of intubation attempts, failed awake intubations, glottic view, mean time to achieve BIS, complications, drug consumption, and patients reported satisfaction. Institutional Ethical Committee approval was taken and the trial was registered in CTRI. It was a randomized controlled trial that included patients from 18 to 70 years of age with ASA grade 1 to 3 with anticipated difficult airway with an L-Ganzori score of 4 to 9, mouth opening or interincisor gap more than 1 finger, requiring nasotracheal intubation for head and neck surgery. The study excluded patients who did not give consent for participation, patients with liver cirrhosis, severe bradycardia, AV block, heart failure, thrombocytopenia, or coagulopathy. Randomization was done using a computer-generated random number table with 15 blocks of 4 patients each. The patients were allotted by 1:1 allocation in 2 groups. Group D, where dexmedetomidine infusion was given, and Group P, where propofol infusion was given. Intubation was done by an independent investigator proficient in CMAC use. One investigator concealed the syringe pumps behind the screen, and participant and the outcome assessor were blinded. All patients received glycopyrrolate as pre-medication. All patients were nebulized with 3 ml of 4% lignocaine and were given a transtracheal block with 2 ml of 4% lignocaine and nasal xylometazoline drops. All patients were then asked to inhale 2 ml of 2% lignocaine jelly nasally. Then the nose was packed with 0.5 ml of 4% lignocaine ribbon-soaked gauge. After the patients were taken inside the OT, they were given IV midazolam and IV fentanyl 1 mics per kg, pre-oxygenation with 100% oxygen for 3 minutes using face mask. In the propofol group, propofol was started at 250 mics per kg per minute. In the dexmedetomidine group, dexmedetomidine was started at 1 mics per kg bolus over 10 minutes, followed by 0.5 mics per kg per hour. And both of these infusion were continued till sedation of BIS 65 to 70 was achieved. Oxygenation was continued with the face mask, and then CMAC D-blade video laryngoscope guided nasotracheal intubation was done with a 7 mm flexometallic endotracheal tube. The primary outcome was intubation score in terms of cough, vocal cord movement, and patient reaction. Lower the score, better was the outcome, that is clinically excellent, and 12 is clinically poor. The secondary outcomes were hemodynamic parameters in terms of heart rate and mean arterial pressure, intubation time defined as time to nasal endotracheal tube insertion to the end of intubation, number of intubation attempts, failed awake intubations, glottic view in terms of POGO score, mean time to achieve the desired BIS of 65 to 70, complications, drug consumptions, and patient-reported satisfaction scores between the two groups. The sample size was based on a previous study where the proportion of patients with no coughing on awake nasotracheal intubation was 60% in dexmedetomidine group and 16.7% in the propofol group. It was at 5% level of significance and 90% power. The sample size was 24 per group. Allowing for 20% dropouts, the final sample size was 30 per group. SPSS version 21 was used for analysis and a p-value of less than 0.05 was considered to be significant. So in the baseline parameters, the age, weight, gender, ASA physical status and L-Ganjari score did not differ between the two groups. In the primary outcome, the intubation scores in terms of cough and vocal cord motion were similar between the two groups. However, in terms of patient reaction, the mean intubation score became higher in the dexmedetomidine group, suggesting that propofol was better in suppressing the intubation response by decrease in the intubation scores. This result was statistically significant. In terms of secondary outcomes, for the hemodynamic parameters during laryngoscopy, intubation, and up till 5 minutes post-intubation, the mean arterial pressure and the heart rate was found to be significantly lower with propofol than with dexmedetomidine. The intubation time, POGO scores, and intubation attempts did not differ significantly between the two groups. However, the time to achieve BIS was significantly lower in the propofol group. The patient-reported outcomes also were better with the propofol group. In the dexmedetomidine group, one patient experienced desaturation during laryngoscopy, whereas no patient in the propofol group had any complications. So in this study, both propofol and dexmedetomidine were found to provide good intubating condition, but propofol's superior suppression of airway reflexes resulted in better intubation scores, making it superior for awake videolaryngoscopic intubation. The low and comparable incidence of cough during intubation in both groups was due to effective transtracheal block and topicalization. While propofol and dexmedetomidine have been used individually as sedatives for awake videolaryngoscopic intubation, there is no published literature comparing their efficacy for this purpose. No patient had closing vocal cords, corroborating findings with previous studies, and this could be attributed to the use of nebulization and lignocaine jelly in all the patients. Propofol better suppressed the intubation stress response, indicated by the lower heart rate and mean arterial pressures compared to dexmedetomidine. The longer onset time and peak effect of dexmedetomidine made propofol more suitable for time-sensitive situations. Comparable intubation time suggests that both drugs facilitate intubation similarly, but propofol required lower second intubation attempts. Their absence of dental or soft tissue trauma was due to minimal patient resistance or struggle. The study limitations include exclusive use of the CMAC-D blade, making results non-generalizable to other videolaryngoscope, and the skill-dependent nature of the technique. The future multicentric randomized control trial using different videolaryngoscopes are needed to compare the efficacy of various sedatives for awake nasotracheal intubation in anticipated difficult airways. Thus, from this study, it can be concluded that propofol infusion provides a better intubation score than dexmedetomidine infusion for awake CMAC-D blade guided nasotracheal intubation in patients with anticipated difficult airway. Thank you.